Welcome to the deep dive. Today, we're tackling a really vital topic: emergency departments.
Absolutely vital.
You, our listener, provided a fantastic range of sources, from a detailed look at triage from NCBI
Yeah, that was a good one.
to the nuts and bolts of hospital disaster plans used in India, and even a study using clever math to figure out nurse staffing in Honduras.
Right, using integer linear programming, which is pretty fascinating in that context.
So our mission today is to make sense of all this information. We want to give you a clear understanding of how these crucial healthcare hubs operate.
And the challenges they face, because there are many.
Exactly. Challenges and also the smart ways people are trying to make them, even better.
Absolutely. The material you shared is excellent, covering the fundamental principles behind emergency care with that triage info and quality benchmarks from organizations like NABH and ISQA, all the way to very practical guidelines.
Like how to handle specific medical emergencies.
Yeah, and ambulance procedures, things like that. We'll be pulling all these threads together to give you a really comprehensive picture.
Okay, great. So let's get down to basics then. When we talk about an emergency department, what exactly is it? Because people use so many different names.
That's true. You might hear it called an ED or A&E, that's accident and emergency, common in the UK.
Right. AN.
Or ER, emergency ward, even casualty department. But the core function, well, our Wikipedia overview explains it. It's about providing immediate medical treatment.
For emergencies and acute illnesses.
Exactly. The key thing is that people arrive without needing an appointment, either on their own or, by ambulance.
And these aren't usually tucked away somewhere obscure in the hospital, are they? I always picture them being pretty easy to find.
You're right. Typically, the emergency department is located on the ground floor of a hospital.
Makes sense.
Sometimes you'll even find them in primary care centers, but always with their own dedicated entrance. This accessibility is just so important when every second counts. And as all our sources highlight, the most critical aspect of how they work is prioritizing patients, sorting them based on how urgently they need medical attention.
Which brings us straight to triage. It sounds straightforward, sorting patients, but it feels like there's a lot more going on than just, deciding who's next. Okay, let's unpack this.
Precisely. The NCBI bookshelf information explains it well. Triage is usually the very first point of contact for a patient.
The first person they see.
Often, yes. It involves a quick initial assessment, checking vital signs like blood pressure and heart rate, and understanding why the patient has come in what they call the chief complaint. Often, a specialized triage nurse takes on this vital role.
Okay.
And what's fascinating here, something maybe not everyone realizes, is that this initial assessment can even happen remotely.
Remotely? How?
Well, ambulance crews can communicate with the hospital via radio, giving them a preliminary overview of the incoming patient before they even arrive.
Oh, wow. So it's like giving the ED a heads up. That makes sense. So after someone goes through triage, what's the process? It's not just one big waiting room, is it?
Not at all. There are different pathways for patients depending on their condition. Someone with a very serious problem like a suspected stroke
Right, something critical.
might bypass the general waiting area and go directly to a critical care section, sometimes called resus or resuscitation.
Okay.
But for most people, after triage, they'll likely be directed to an acute care or majors area for a more thorough examination by a doctor, especially if they show signs of a significant illness but aren't in immediate life-threatening danger.
And what about less serious cases?
Well, on the other hand, if someone has a very minor issue, they might even be treated right there at the triage stage, or perhaps directed to a minors area, or even advised that the ED isn't the most appropriate place for them.
Our NCBI source also delves into different systems used for triage, like ESI and START, right? Can you tell us a bit about those?
Yes, definitely. In the United States, the START system, that simple triage and rapid treatment, is widely used for patients older than 8.
Okay, START for older than 8.
It's designed to be very quick, aiming for under a minute per patient. It focuses on key indicators, pulse, breathing rate, capillary refill time.
That's pressing on a fingernail.
Exactly. Also, any major bleeding, and crucially, whether they can follow simple instructions.
And for kids?
For children, there's Jumpstart. It's an adaptation because kids are more susceptible to breathing problems and might not always be able to understand verbal commands quite the same way.
Makes sense to adapt it for children.
And importantly, as the NCBI source emphasizes, triage is not a one-time thing. It's dynamic.
Meaning?
Meaning a patient's condition can change, sometimes rapidly, so their triage status can be reassessed as needed while they're in the ED.
Okay, good point. And ESI? That sounds like it's based on how many resources a patient is likely to need.
Exactly. The Emergency Severity Index, or ESI, essentially asks, how many tangible resources beyond the basic assessment will this patient likely consume?
So it helps sort people based on expected workload.
Precisely.
Yeah.
It helps differentiate between someone needing extensive investigation versus someone with a more straightforward issue. ESI uses the anticipated number of hospital resources to categorize patients into levels 3, 4, and 5.
What do those levels mean?
Level 3 suggests a need for 2 or more resources, level 4 indicates 1 resource, and level 5 means no resources are anticipated beyond the initial assessment.
And what counts as a resource?
Good question. Generally, things like lab tests, blood work, urine tests, ECGs, x-rays, or other imaging like CT scans, medications given intravenously or through a nebulizer.
Like for asthma.
Right. Also specialist consultations and any procedures, whether simple like stitches or complex ones.
And what doesn't count?
Things like taking a patient's history and doing a physical exam, just starting an IV line but not giving meds through it, giving oral medications, simple wound care like cleaning and bandaging, or giving out crutches or splints. Those usually don't count as ESI resources.
Huh. So it's quite specific.
Very specific. And what's interesting is that the exact definition of a resource can vary slightly from one hospital to another.
Really? Like what?
Well, for example, a simple urinalysis might be considered a resource in one institution but not in another, so there's some local variation.
So even these well-defined systems have some flexibility.
They do, and the ESI system clearly defines what isn't a resource too, which is crucial for consistency. Then you have other triage scales used around the world.
Like the ones mentioned in the source, ATS and MTS.
Exactly. The Australasian Triage Scale, ATS, and the Manchester Triage System, MTS, are common. The NCBI source mentions some research. Well, it showed mixed results regarding how consistently and effectively the Manchester Triage System performs.
Mixed results how?
Particularly when it comes to older adults and children. Some studies suggested it might not be as reliable for predicting hospital admission or severity in these groups compared to middle-aged adults.
That's interesting. So even these established systems might have, areas for improvement. Or maybe they work better for certain patient groups.
The research suggests there can be inconsistencies, yeah.
Oh.
Potentially because older patients often have more complex and interacting medical conditions.
Okay.
However, one study did find that the MTS was actually better at predicting mortality in surgical patients over the age of 65. So it's not entirely straightforward.
It really highlights the ongoing need to study and refine these vital assessment tools, doesn't it?
Absolutely. Triage is the gateway. Getting it right is fundamental.
Okay, so we have patients arriving, being assessed through triage, and then moving into different areas for care. But we also know that emergency departments are often incredibly busy places. Let's talk about the challenges.
Overcrowding and the flow of patients through the department are definitely significant issues. Both our Wikipedia overview and that review article really emphasize this.
I saw a statistic in there, something like 128 million visits in the U.S. in 1 year.
Yeah, back in 2009. It's a huge number. And a large portion of these visits are for children and older adults, people under 18 and over 65.
And while most people are treated and released.
Right, the majority are. But a substantial number do need to be admitted to the hospital. And that's where problems can really start.
The wait times.
Exactly. Long waiting times aren't just frustrating. They can have really serious consequences. Delays in treatment can lead to worse outcomes, injuries, even deaths in tragic cases, not to mention patient dissatisfaction.
The Wikipedia entry mentions some pretty concerning things about EDs operating way beyond their intended capacity.
Oh, absolutely. Surveys have shown EDs frequently operate over capacity.
And even having to divert ambulances to other hospitals. That sounds incredibly stressful for everyone involved.
It is. Ambulance diversion, where ambulances are basically told, we're full, go somewhere else, is a really controversial practice. Some regions have even tried to ban it because of the potential risks.
Wow. It just underscores the immense pressure these departments are under.
It really does.
Yeah.
And patient flow, how patients move through the ED, is absolutely critical. That review article breaks down a patient's stay into 3 connected phases.
Okay, what are they?
There's the inflow, which is essentially arrival and triage. Then the treatment phase, or throughput, where they're actually being seen, tested, treated. And finally, the outflow.
Outflow being discharge, admission.
Right. Discharge home, admission to an inpatient bed in the hospital, or perhaps transfer to another facility if needed.
And it sounds like that last phase, outflow, is often where things get really stuck. like a traffic jam.
That's often the biggest bottleneck, yes. Inefficient outflow, frequently caused by a lack of available inpatient beds upstairs,
Right.
is a major contributor to ED overcrowding. It's sometimes referred to as boarding.
Boarding. Because patients are stuck, like waiting for a train.
Sort of, yeah. They're admitted they need a hospital bed, but there isn't one ready. So they remain in the ED, sometimes for hours, even days in extreme cases, taking up space and staff attention needed for new emergencies.
That must be incredibly frustrating for patients and staff alike. So what are some of the ways hospitals are trying to improve this flow?
Well, several strategies are being looked at and implemented. One approach, though it has its drawbacks, is sometimes using designated space within the ED as a temporary holding area for admitted patients waiting for beds.
Kind of like an internal waiting room.
A bit, yes. Other, maybe more proactive strategies include using visual data tools like dashboards we'll talk about later to better coordinate when patients are discharged from inpatient units, freeing up beds sooner.
Okay, using data.
And setting up fast-track systems within the ED for patients with less urgent medical needs, so they can be seen and treated more quickly without getting caught up in the flow for more complex cases.
Separating the streams a bit.
Exactly. But as one of our research articles points out, addressing that fundamental bottleneck, the difficulty in moving admitted patients out of the ED and into those inpatient beds remains key.
It sounds like a whole hospital problem, not just an ED problem.
It absolutely is. The ED is often just where the symptoms of system-wide capacity issues become most visible.
This must all put a huge strain on the staff, particularly the nurses. We even have that study looking specifically at nurse staffing in Honduras. What did it find?
That study really highlights the challenges that come with not having enough nurses or maybe not having them scheduled optimally. They found high levels of work-related exhaustion among the nurses there.
I can imagine.
And as the researchers point out, this kind of burnout can increase the chances of errors, mistakes in administering medications, lapses in critical judgment, things you absolutely want to avoid in an emergency setting.
Definitely. Did they have a solution?
They used a mathematical approach, actually, integer linear programming, with a tool in Excel called OpenSolver to try and figure out the best way to schedule the existing nurses.
Like solving a complex puzzle. And what did their analysis show? Did they just need more nurses?
Interestingly, no, not necessarily. Their findings suggested that the current number of nurses they had might actually be sufficient if their shifts were arranged more effectively.
So optimization was key?
It seemed to be. The model aimed to maximize the number of assigned shifts while respecting constraints, like the total number of nurses available and the different types of shifts needed.
Did they find any downsides?
Well, they did note it was difficult to guarantee weekend days off for all nurses with the current staffing levels, even with optimization. The study emphasizes looking at both daily assignments and how shifts are spread across the whole month.
And considering experience levels, too?
Yes, they even factored in setting minimum and maximum numbers of more experienced licensed nurses per shift. So it's not just about bodies, it's about the right mix of skills and experience at the right times.
So it really drives home that efficient scheduling is just as crucial as the absolute number of staff. Now let's talk about technology. How do electronic health information systems, HANS, play a role in managing patient flow?
Oh, HENS have a really significant impact. Huge! Our systematic review looked at research spanning several decades on this.
And what did it find?
It found that key features of these systems really influence how efficiently patients move through the ED and the hospital.
What kind of features are we talking about?
Things like being able to track where a patient is electronically at any given moment, managing documentation notes, orders, results digitally.
CPOE, computerized order entry.
Exactly. Electronic order entry for tests and treatments, patient registration systems, bed management tools to see bed availability in real time.
That seems crucial for the outflow problem.
Absolutely. Also, clinical decision support tools embedded in the system, discharge management modules, electronic prescriptions, and importantly, systems that can generate reports on patient flow metrics.
So they help manage the process and provide data to see how well it's working.
Precisely.
And the overall effect is generally positive.
Yes, overall, the review found that the majority of studies reported positive impacts of HERE-YES on important patient flow measures.
Like what specifically?
Things like shorter length of stay in the ED, reduced waiting times for care, faster turnaround times for tests and treatments.
All good things.
Definitely. Also, less time patients spend boarding while waiting for an inpatient bed, fewer patients leaving without being seen by a doctor.
That's a big one, LWBS rates.
It is. And even improvements in patient satisfaction, staff satisfaction, potential cost savings for the hospital, and maybe even reduced stress for the staff, but that's harder to measure.
That's a pretty compelling list of benefits. It sounds like these systems are becoming pretty essential tools for a modern ED.
I'd say they are, yes.
Yeah,
Though implementing them well is also key.
of course. Now, shifting gears slightly. Emergency departments also have to be prepared for unexpected events, right? Not just the daily rush, but major incidents, internal emergencies, or even external threats.
Absolutely. Preparedness is critical. We have some examples of internal hospital disaster plans from the sources that illustrate this very well.
Like for a fire inside the hospital.
Exactly. For internal emergencies like a fire, there are very specific procedures. Notification chains alerting the admitting office, broadcasting alerts to all departments, department heads notifying their key personnel.
A clear communication plan.
Crucial. Evacuation plans to designated safe areas are mapped out, and staff will take roll calls to make sure everyone, patients, staff, visitors, is accounted for.
And managing the situation itself.
The plans detail setting up a temporary receiving area, often in the emergency department hallway, for initial triage of anyone affected by the internal event, and establishing a command center, usually located in or near the ED, or casualty as it's sometimes called, and a visitor control center, maybe in the front lobby.
And normal operations might change.
Yes. Interestingly, the protocols mention that regular visiting hours might be temporarily suspended during an internal alert to manage chaos and ensure safety.
Okay, that covers internal events. What about external incidents? Things like riots or bomb threats?
The protocols address those serious situations too. In the event of something like a riot near the hospital, or if a VIP is admitted needing extra security.
Right, that happens.
Immediate steps include securing entrances and exits, locking down the facility, and notifying the police for security support. They even mention the possibility of issuing a specific alert code, like a yellow alert, indicating a heightened state of preparedness.
And bomb threats. That must be terrifying.
Extremely serious. There are specific guidelines for whoever receives the warning call. Try to keep the caller on the line, note any voice characteristics, background noises, the exact wording used.
Gather intelligence.
Exactly. Then, search procedures are initiated. The protocols note that hospital staff often know the building layout better than external authorities, so they play a key role in the search.
And if something suspicious is found?
The crucial instruction is, do not touch IT. Clear the area immediately, isolate it, and call specialized bomb disposal units. Evacuation is generally a last resort only if a device is confirmed, and that decision is made in coordination with police.
Very clear, very structured response needed. We also have information on how ambulance services operate with the ED. What are some key protocols there?
Ambulance services are obviously tightly integrated with the ED. They work very closely to coordinate the smooth and safe transfer of patients.
Who directs the ambulances?
Usually, the movement of ambulances on hospital grounds is directed by the emergency medical officer, or EMO, though in certain situations, senior hospital administrators might also get involved.
And keeping the ambulances ready?
That's vital. Regular checks are mandatory to ensure ambulances are fully stocked and prepared medical kits, oxygen, medications, all equipment functioning.
And cleanliness, especially now.
Absolutely critical. There are detailed procedures for cleaning and disinfecting the ambulance after every patient transport, with specific, stricter guidelines if the patient had a known or suspected infectious disease.
Makes sense. Now, what about medico-legal cases? MLCs, as they're referred to in the documents. That sounds like it needs careful handling.
Extremely careful handling.
Yeah.
The standard operating procedures we reviewed emphasize meticulous documentation, recording all complaints, the sequence of events, dates, times, locations, any individuals or vehicles involved. Every detail matters.
And informing the authorities.
Yes, typically these cases are reported to the relevant police station. The SOPs mention counseling the patient or their relatives about this hospital policy first.
And if the patient unfortunately dies?
In the sad event of a death classified as an MLC, a post-mortem examination is usually mandatory, and the body is typically handed over to the police for legal formalities, rather than directly to the family initially.
A very sensitive but necessary procedure. Finally, on protocols, our sources cover procedures for when a patient is admitted, discharged, referred, or transferred. Key points there.
Okay, so for patients arriving critically ill, the first priority is always assessment and stabilization in the ED before moving them. Once stable, they typically go directly to the intensive care unit, the ICU.
Bypassing a regular ward.
Often, yes, if they're that critical. Patients needing urgent surgery, maybe from major trauma or certain obstetric emergencies, they get prepared for the operating room right there in the emergency department.
Okay. And transfers out of the hospital.
If an unstable patient needs to be transferred to another facility, perhaps for specialized care not available,
Right.
a comprehensive referral summary outlining their condition and treatment so far must be prepared. They have to be transported in a properly equipped ambulance, maybe even a mobile ICU, with trained medical staff who can monitor and manage them during the entire journey.
Ensuring continuity of care.
Exactly. And lastly, even handling death summaries and the release of a deceased patient's body involves strict procedures, including careful verification of the patient's identity before any death certificate is issued or the body is released.
It's really striking just how detailed and comprehensive all these protocols have to be, covering such a wide array of potential situations.
They have to be. In an environment where stakes are high and things move fast, clear procedures are essential for safety and efficiency.
Now, shifting focus slightly, our listener also sent us some standard operating procedures for managing common medical emergencies, specifically from India. What are some key takeaways from those?
These SOPs offer really crucial initial guidance for the public and first responders. For a heart attack, the emphasis is on recognizing risk factors and, most importantly, taking immediate action.
Like calling for help right away.
Absolutely. Calling emergency services, the numbers 112 or 108 are mentioned for India, helping the person get into a comfortable position, often semi-sitting, and crucially, not delaying seeking medical treatment. Time is muscle, as they say.
Time is muscle. Got it. What about stroke?
Similar advice for stroke. Recognize the fast signs: face drooping, arm weakness, speech difficulty. Time to call emergency services. Again, immediate medical attention is critical to potentially limit brain damage.
Okay. What about situations like poisoning or an overdose? They seem common too.
They are. In the case of poisoning, the first step is to quickly and safely assess the situation. Try to figure out what substance was involved, how much, when.
If possible.
If possible, yes. Again, calling for emergency medical help is the top priority. The SOPs mention that if it's safe to do so, bringing the suspected poison or its container to the hospital can be very helpful for the medical team to identify it and plan treatment.
Good tip. And overdose.
For both medication overdose and alcohol poisoning, recognizing the signs and symptoms is critical. Things like altered consciousness, breathing problems, vomiting. And again, immediately seeking professional medical assistance is key.
Is there any first aid mentioned for alcohol poisoning?
Yes, important steps include making sure the person's airway is clear, putting them in the recovery position to prevent choking if they vomit, and keeping them warm while waiting for help. Don't leave them alone.
Okay. And heavy metal poisoning. That sounds particularly serious and maybe less obvious.
It is serious, and the symptoms can vary a lot depending on the specific metal, lead, mercury, arsenic, etc. Initial first aid might be limited, perhaps rinsing the person's mouth if they ingested something corrosive, but inducing vomiting is often not recommended.
Why not?
Because corrosive substances can cause more damage coming back up. The absolute key message is, do not delay getting the person to a medical facility, preferably one with expertise in toxicology, as specialized treatments like chelation therapy might be needed.
So it sounds like across these common emergencies, the pattern is quick recognition, call for professional help immediately, provide basic supportive first aid if safe and appropriate, and get the person to definitive medical care fast.
That's the core message, yes.
Yes.
Early intervention saves lives.
Now, we've talked quite a bit about the challenges EDs face, overcrowding, flow issues. What are some of the broader strategies being implemented or studied to improve their overall efficiency? Our listener shared a qualitative study that looked into this.
Right. That study explored various strategies aimed at reducing inefficiencies. And a major theme that emerged, maybe unsurprisingly, was the vital role of communication.
Communication between staff.
Exactly. Clear, consistent communication, effective information sharing, and strong collaboration among all the clinical staff, nurses, doctors, techs, everyone. This aligns with organizational values that emphasize efficient communication.
So everyone needs to be on the same page.
Pretty much. They found that making sure information is shared promptly across the entire ED team and fostering ongoing collaboration are just essential for smooth operations.
Did they mention the impact of electronic records on this?
They did. Interestingly, while acknowledging the many benefits of EHRs, they also pointed out that sometimes reliance on the screen can impact face-to-face communication.
Oh, interesting point.
Yeah, so they suggested a potential need for specific training to enhance those direct communication skills among clinical staff, even in a high-tech environment.
The study also looked at ways to optimize the triage process and overall patient workflow, didn't it? Using a systems approach.
Yes, they framed it using systems theory, thinking about inputs, patients arriving, throughput, care within the ED, and outputs, leaving the ED.
And what suggestions came from that?
One interesting suggestion was the idea of using a physician in triage, sometimes called physician-led triage or doc in a box. The idea is that they could potentially speed up the initial assessment, order tests earlier, and maybe even initiate treatment faster for some patients.
Get the ball rolling quicker.
That's the hope. They also emphasized the importance of different departments within the hospital working together better to track a patient's entire care journey, maybe using shared reporting tools.
Breaking down silos?
Exactly. And addressing the impact that lower acuity patients, those with less urgent conditions, can have on the overall emergency flow. Maybe by developing robust alternative pathways or fast-track systems, as we mentioned earlier.
Did the pandemic influence this?
The study noted that the COVID-19 pandemic forced many EDs to adapt quickly, implementing strategies like transferring stable patients to nearby hospitals when their own capacity was overwhelmed. It showed the need for flexibility and innovation.
So continuous improvement is key.
Absolutely. Adapting and innovating workflow models, implementing effective fast-track triage processes, these are ongoing efforts.
And what about the staffing challenges we touched on earlier? Did the study add anything there?
It did echo some of those concerns. It recognized the limitations of relying too heavily on part-time or agency nurses who might be less familiar with specific hospital processes.
And new graduates.
Yes, it mentioned the challenges faced by new nursing graduates who might lack extensive practical clinical experience, especially in a high-pressure ED environment.
So training is crucial.
Hugely important. They highlighted the need for comprehensive training and robust onboarding programs for all new nurses. They also acknowledged that inexperienced staff can sometimes create bottlenecks, not just in the ED, but also impacting supporting departments like lab and radiology if orders aren't quite right, for example.
Right, the knock-on effects.
Exactly.
Yeah.
The key takeaway for professional practice, they suggested, is the need to constantly strive for higher standards in communication, in staff training, in workforce forecasting and planning, and developing effective staffing models.
And collaboration across the whole system.
Yes, fostering better collaboration across the entire healthcare system to create smoother patient treatment plans and transitions. Addressing delays in getting lab and radiology results back quickly. All these things matter.
It really sounds like improving ED efficiency requires looking at the bigger picture, doesn't it? Considering the entire patient experience and how all the different parts of the hospital system interact.
That's a perfect summary of it. It's rarely just one thing.
Finally, let's talk about how emergency departments actually measure how well they're doing. We have an article on key performance indicators, KPIs, used in ER dashboards. What kind of information do those dashboards provide?
Right, so emergency room dashboards are basically visual displays. Think of screens up in the department showing real-time operational information.
Like an air traffic control screen, but for patients.
Kind of, yeah. KPIs and the analysis of the data they display are crucial for monitoring what's happening, evaluating performance, and ultimately improving both patient care quality and operational efficiency.
So what gets measured? Patient throughput must be big.
Definitely. Patient throughput, how quickly and smoothly patients move through the system, is a major focus. Metrics like door-to-provider time.
How long from arrival until they see a doctor or nurse practitioner?
Exactly. That evaluates how efficiently the initial assessment and triage are working.
Yeah.
Then there's the overall length of stay, or LOS.
The total time in the ED.
Right, from arrival to departure. That's vital for understanding how resources are being used and for spotting potential bottlenecks. If LOS starts climbing, something's likely backing up.
And wait times for specific things.
Yes, tracking how long patients wait for specific treatments, or for test results, or for a bed upstairs. Those are all important for patient satisfaction, obviously, but also for understanding staff productivity and identifying specific process delays.
Beyond just how quickly patients move, what other things do these dashboards help track?
They also monitor resource allocation. Are staffing levels appropriate for the current patient volume? Is equipment like CT scanners being used effectively, or is there a queue? Identifying inefficiencies there.
Makes sense. Anything else?
Yes, some dashboards include public health and epidemiological metrics. Tracking the types of illnesses presenting, like flu cases or specific symptoms, can act as an early warning system for potential outbreaks in the community.
Disease surveillance right from the front line.
Exactly. And finally, medication management is another critical area. Dashboards can track things like medication error rates, a key safety indicator, and also how well staff are adhering to established medication protocols, which reflects care quality and efficiency.
So these dashboards really provide a valuable real-time snapshot of the ED's health, highlighting areas that might need attention or improvement.
That's precisely their purpose, data-driven improvement.
This has been an incredibly informative deep dive into the really complex world of emergency departments.
It really has. We've covered a tremendous amount of ground, I think. From the fundamental principles of triage and those persistent challenges like overcrowding, to the vital importance of well-trained, well-scheduled staff, the growing role of technology in streamlining processes, and the absolute necessity of having clear, robust protocols for everything from disasters to patient transfers.
And we touched on the initial steps for managing some common serious medical emergencies too. And one particularly interesting point for me, thinking back, was that study in Honduras suggesting their current nursing staff might be sufficient if scheduling was optimized.
Yes, that was intriguing.
It really underscores that sometimes, fixing the process can be just as impactful, maybe even more so, than just throwing more resources at a problem.
That's a great point. Process improvement is key.
Also, the fact that different hospitals might have slightly different definitions of what counts as an ESI resource, that just shows how nuanced these systems can be when you get down to the practical application.
Absolutely. Context matters, local definitions matter, and having this kind of understanding of the inner workings, the pressures, the systems, it provides valuable context.
For anyone, really, whether you work in healthcare or you're just interested in how these critical community services function.
Exactly. Recognizing the complexities involved definitely gives you a greater appreciation for the dedication and skill of the emergency department staff everywhere. They do incredible work under difficult circumstances.
So, a question for you, our listener. What other aspects of emergency care do you find particularly interesting? Are there specific challenges maybe you've personally encountered or read about that you'd like us to explore in a future deep dive? Let us know.
It's clear that as our healthcare systems continue to evolve and face new pressures, that ongoing focus on improving efficiency, patient flow, and the quality of care delivered in the emergency department, well, it's going to remain a absolutely crucial area for innovation and improvement.
Directly impacting the health and well-being of all our communities.
Couldn't have said it better myself.